Hello. The slides that you're about to see were prepared by Dr. Gregory Fuller from the MD Anderson Cancer Center in Houston, Texas. The title of this presentation is Integrative Approach to CNS Tumor Diagnosis and Classification in the era of the 5th edition of the WHO classification system for CNS tumors. My name is Leo Ballester, and I'm an assistant professor at the University of Texas Health Science Center at Houston, and I will be sharing with you the slides that have been prepared by Dr. Fuller. In 2021, we follow an integrative approach to brain tumor diagnosis, and that will be the focus of this presentation. Diagnosis follows an 8-data sphere model, and you can see the 8 spheres here on the slide, which include the age of the patient, gender, clinical information, anatomic location, imaging characteristics, histology, differentiation markers, and molecular signature. And here in the center, where these spheres overlap, is the patient's diagnosis. All this information is available to the pathologist via the electronic medical record. Two of these spheres are evolving very rapidly. Molecular signature determination. It's something that has been incorporated routinely now into the diagnosis of CNS tumors, and there have been significant changes in our understanding of the molecular alteration associated with brain tumors, in particular with diffuse gliomas. And preoperative imaging, which is also a field that is advancing rapidly, in particular with the incorporation of MRS. And in many ways, imaging is pathology. And in 2021, the diagnosis of brain tumors is based in a combination of the 8 spheres that I just mentioned, but imaging and histology, as well as molecular alterations, are critical. There have been 7 articles released by the CE Impact Now working group. And these 7 updates have outlined the major changes coming in the 5th edition of the WHO classification of central nervous system tumors, which was quoted as WHO 2020. Publications was delayed and is now expected to be released in 2021. Those 7 articles are listed here. 2 of them here in the bottom, update 6 and 7, as well as 5. Actually, updates 5 and 6 are the ones that perhaps discussed in more detail the changes recommended for the diagnosis and grading of diffuse gliomas. And when we look at diffuse gliomas, we can separate them in 2 types, adult type and pediatric type. And the adult type diffuse gliomas have different molecular alterations than the pediatric type diffuse gliomas. So it's not only an age difference, there is a difference in the molecular drivers for adult gliomas and pediatric gliomas. So let's focus on adult type diffuse gliomas. Under the 2016 WHO classification system, the adult type diffuse gliomas were classified in one of these entities that you can see in the screen. They were diffuse astrocytomas, and they were either IDH mutant or IDH wild type, and WHO grade 2. anaplastic astrocytomas, which could be IDH mutant or IDH wild type, WHO grade 3, and glioblastoma, which could be IDH mutant or IDH wild type, and WHO grade 4. IDH mutant versus wild type refers to the presence or absence of mutations in isocitrate dehydrogenase genes, IDH1 or IDH2. For oligodendrogliomas, there are two categories: oligodendroglioma, IDH mutant, 1p19q co-deleted, WHO grade 2, and anaplastic oligodendroglioma, IDH mutant, 1p19q co-deleted, WHO grade 3. And the presence of both an IDH mutation and 1p19q co-deletion are required for the diagnosis of oligodendroglioma under the 2016 WHO classification system. Now, these terms, oligoastrocytoma, WHO grade 2, and anaplastic oligoastrocytoma, WHO grade 3, which were previously used under the 2016 WHO classification system, were discouraged because these entities could be classified as either astrocytomas or oligodendrogliomas by incorporating the molecular alterations, which include IDH mutations and 1p19q co-deletion, among a few others. Under the new WHO that will be released in 2021, this has been simplified to the three entities that you can see on the screen. There are astrocytomas, IDH mutant. There are oligodendroglioma, IDH mutant, 1p19q co-deleted. And the difference here between the astrocytoma, IDH mutant, and the oligodendroglioma, IDH mutant, is the presence or absence of the 1p19q co-deletion. And there are glioblastomas, which are IDH wild type. If we look at an example of an astrocytoma, IDH mutant, here we have a 25-year-old female. So this is a younger patient than the classic presentation of a glioblastoma, which would be in a patient in their 60s, for example. So 25-year-old female. Here we can see the imaging. There's an axial T2 weighted image on the left showing T2 hyperintensity in the left temporal lobe. You can see the T2 flare here and the T1 with contrast, showing that there's no contrast enhancement. So what would be the diagnosis based on the information that we have so far? We have age and we have imaging characteristics. Well, there's non-enhancing glioma in an adult patient, which has the T2 flare mismatch sign. The T2 flare mismatch sign refers to the hyperintensity seen in the T2 weighted image becoming hypointense in the T2 flare sequence. And this is highly specific for IDH mutant diffuse astrocytic disease. Here's one study from 2017, and the conclusion was that the T2 flare mismatch sign was a highly specific imaging biomarker for the identification of IDH mutant, 1p19q non-co-deleted, so 1p19q intact, molecular subtype of diffuse glioma. So we're talking about IDH mutant astrocytomas, because if the IDH mutant 1p19q co-deleted tumors will be oligodendrogliomas. So T2 flare mismatch is a highly specific imaging biomarker for IDH mutant astrocytomas. Here's another study which validated this finding in 2018 in neuro-oncology, showing that the T2 flare mismatch sign is again a highly specific imaging biomarker for IDH mutant astrocytoma. It has 100% positive predictive value. Here you can see T2 flare sequence for 8 different patients showing the T2 flare mismatch sign, where you can see this hypointensity in the T2 flare sequence. All of these 8 patients had tissue-proven IDH mutant diffuse astrocytic disease. If we look at the histology of the 25-year-old patient that we were discussing earlier, we can see that there is hypercellularity. So there's more cells than you would have in normal brain tissue. And these cells are pleomorphic. So they have irregular shapes. There are microcysts. You can see these little cystic spaces in the background. This tumor had elevated mitotic activity, but it didn't show the presence of vascular proliferation or microvascular proliferation and no necrosis. And these microvascular proliferation and necrosis are histologic features that are associated with WHO grade 4 tumors. In the case of diffuse gliomas. So by histology, this tumor would have been diagnosed as a WHO grade 3 following the 2016 histologic-based grading criteria. It would have been an anaplastic astrocytoma, WHO grade 3. And this is an immunohistochemical stain showing the expression of the IDH1 mutant protein. And the most common mutation in diffuse gliomas is the arginine at codon 132 mutated to histidine, R132H. This IDH1 R132H mutant tumor. So this again goes with the presence of the T2 flare mismatch sign that we saw earlier on the imaging of this patient. So here we are confirming by immunohistochemistry the presence of the IDH1 mutant protein. You can see how all, which is represented by this brown staining. If you look at higher magnification, you can see here the tumor cells expressing the IDH1 mutant protein shown by this brown color. If you look at the blood vessel in the center, you can see the red blood cells there in the lumen of the blood vessel. These endothelial cells are not expressing the IDH1 mutant protein. So you see the counter stain, which is this blue color, but no the brown color, which is associated with the antibody that recognizes the IDH1 mutant protein, is not present in these endothelial cells. So these cells are IDH1 wild type. They do not have the mutation. But there is strong diffuse expression of mutant IDH1 R132H protein. This is an immunohistochemical stain showing p53 expression, and there is also a strong diffuse nuclear expression of p53 in this tumor, which is associated with the presence of a p53 mutation. So we can see that the tumor in this patient has an IDH1 R132H mutation, which I just showed you, and it has a p53 mutation, which is identified by the expression of p53 by the tumor cells. This is another immunohistochemical stain for a different protein, the ATRX protein. You can see how this blood vessel in the center, the endothelial cells, do express ATRX. There's a brown staining in those cells, whereas all these cells in the background, these blue nuclei, represent tumor cells that do not express ATRX. So the protein is absent. There are a few cells in the background that show expression of ATRX. Those are the normal glial cells in the brain parenchyma, because these are diffuse gliomas. They infiltrate normal brain parenchyma. So here we can see tumor cells that do not express ATRX. They have loss of ATRX expression due to a mutation in this protein, and they are surrounding these normal brain cells that do retain normal expression of the ATRX protein, similar to the endothelial cells in the blood vessel. So this tumor shows loss of expression of ATRX in the glioma cells. And this combination, this triad of IDH mutation, and it can be IDH1 or IDH2, TP53 mutation, and mutations in ATRX, which are represented by loss of ATRX expression, this triad is the classic molecular alteration of IDH mutant diffuse astrocytic disease. So these tumors have mutations in these three genes, and these are the molecular drivers of IDH mutant diffuse astrocytic tumors. Data from the Cancer Genome Atlas in this paper that was focused on lower grade gliomas summarizes the molecular alterations of diffuse gliomas. And there are essentially three types when you look at the molecular alterations. You have diffuse gliomas, lower grade gliomas here, grade 2 or 3, which have an IDH mutation and one p19q co-deletion. These are the oligodendrogliomas. They're IDH mutant and one p19q co-deleted. And if you look at what other mutations are present in these tumors, they typically have inactivated mutations in these three genes, CIC, FUBP1, and Notch1. And they may have activated mutations in these other genes, PIK3CA, TERT, IDH1, or IDH2. So these are the molecular alterations of oligodendrogliomas. Here we can see IDH wild-type tumors, which would be glioblastomas, IDH wild-type, frequently have alterations in PTEN, NF1, CDKN2A, and activated mutations in EGFR, TERT, or MDM4. And the third category are the IDH mutant tumors that do not have 1p19q co-deletion. 1p19q co-deletion is absent. And these are the diffuse astrocytomas, IDH mutant, which have, as I just showed you, mutations in TP53 and ATRX, inactivated mutations in these two genes, or also could have activated mutations in MYC, CCND1, IDH1, or IDH2. So these are the three categories of gliomas when you look at the molecular alterations. So under 2016, the diagnosis of this 25-year-old patient would have been anaplastic astrocytoma, IDH mutant, WHO grade 3. We look at this article from the C-Impact Now working group, which has recommendations for grading criteria for IDH mutant astrocytomas. And this other article, the update number 6, we will see that the diagnosis will change. Under the 2016 criteria, we have diffuse astrocytoma, anaplastic astrocytoma, and glioblastoma. This has changed to just the term of astrocytoma, IDH mutant, and the grade, which would be 2, 3, or 4. And an astrocytoma, IDH mutant, grade 4, is no longer called glioblastoma. Glioblastoma is reserved for IDH wild-type diffuse astrocytomas. So there is no IDH mutant glioblastoma under the 2020 or 2021 WHO classification system. So what is an astrocytoma IDH mutant WHO grade 2? It's an infiltrating astrocytic glioma with an IDH1 or IDH2 mutation that lacks histologic features of aneuploidia. So no mitotic activity or very low mitotic activity, no microvascular proliferation, no necrosis, and no homozygous deletion of CDKN2A and B. The grade 3 tumor, it's also an infiltrating astrocytic glioma with an IDH1 or IDH2 mutation with anaplasia, which basically represented by significant mitotic activity. However, microvascular proliferation, necrosis, CDKN2AB homozygous deletions are absent. So the difference between a grade 2 and a grade 3 is essentially increased mitotic activity in the WHO grade 3 tumors. And the grade 4 tumors do exhibit microvascular proliferation or necrosis or homozygous deletion of CDKN2AB, or any combination of those three. So going back to this 25-year-old patient with a T2 flare mismatch sign, non-enhancing tumor. 2016 diagnosis, anaplastic astrocytoma, IDH mutant, WHO grade 3. 2020 diagnosis, astrocytoma, IDH mutant, WHO grade 3. So this association between diffuse and anaplastic and the grade of the astrocytomas is eliminated in the most recent classification system. Now, the CDKN2AB status of this tumor is unknown. If there was homozygous deletion of CDKN2AB, this tumor would be a WHO grade 4 instead of a WHO grade 3. And the prognostic power of histologic grading in IDH mutant gliomas is something that remains under consideration. Let's move on to another patient, 49-year-old female. You can see T2 hyperintensity on the right, T2 flare, and no contrast enhancement. Non-enhancing disease in a 49-year-old patient with no T2 flare mismatch sign. Magnetic resonance spectroscopy. Here you can see in the normal brain region in the opposite hemisphere, you see what's considered a normal Hunter's angle. And in the other hemisphere where the lesion is, you see an inverted Hunter's angle, which is associated with this elevated choline creatinine ratio and elevated choline NAA ratio. So this is representing densely cellular, likely anaplastic astrocytoma, WHO grade 3 tumor. Here we see histologic imaging from this lesion. And at the top, we see there is hypercellular brain parenchyma with pleomorphism. This immunohistochemical stain for phosphorylated histone protein, PHH3, recognizes cells that are undergoing mitotic division. So here we have 1, 2, 3 cells that show expression of this phosphorylated histone protein. And in this last image at the bottom, we can see cells expressing Ki67, which is a proliferation marker, and it's elevated. There's increased Ki67 labeling in this tumor. So we have a tumor with astrocytic morphology, no microvascular proliferation, no necrosis, elevated mitotic activity, and elevated Ki67 index. Under the 2016 WHO classification system, this would have been an anaplastic astrocytoma, WHO grade 3. Let's look at additional molecular signature determination by immunohistochemistry. These tumor cells do not express the histone 3 K27M mutant protein. There is no labeling with the antibody. And this histone 3 is lysine 27, which is mutated to methionine in some gliomas, is intact in this tumor. The same lysine 27 in the histone protein is normally trimethylated. So this antibody recognizes the mutant protein with a mutation in lysine 27 to methionine. This antibody here recognizes the normal histone protein with the trimethylated lysine 27. And this is a normal scenario where all these tumor cells express histone 3 with trimethylated lysine 27. ATRX protein is expressed in all tumor cells. You can see here, this is in contrast to the prior patient that had a mutation in the ATRX gene, and there was loss of expression of ATRX in the tumor cells. In this particular case, now there is retained expression of ATRX in the tumor cells, which would be normal. And P53, there are a few cells in the background that show some weak staining, but there's no diffuse strong expression of P53 like we saw in the prior case. So the tumor in this patient is negative for H3K27M. It has retained normal trimethylation of lysine 27. It has retained normal expression of the ATRX protein. And it shows nuclear P53 expression only in a minority of tumor cells, and that is not associated with a P53 mutation. So it's histone 3 wild type, ATRX wild type, P53 wild type. This is a representation of next generation sequencing results. All the genes that are shown here were evaluated by the next generation sequencing assay, were interrogated for the presence or absence of mutations. The genes that are circled in red are the genes where an alteration was identified. So in this particular tumor, there was an alteration identified in the third gene, telomerase reverse transcriptase, MDM2, EGFR, and CDK4. If you look here at IDH1 and IDH2, these two genes, no mutations were identified. So we're looking at an IDH wild type glioma. And just like I showed you with the immunohistochemical staining, ATRX protein, also no mutations were identified. That's consistent with the retained expression of that protein by immunohistochemistry. And here we see TP53 also, no mutations were identified. So let's look at TERT. There's a classic, the canonical TERT promoter mutation, which leads to increased levels of the reverse transcriptase. It's present in this tumor. And EGFR amplification. So you can see EGFR amplification here in chromosome 7. So what would be the diagnosis in this case? Well, in 2016, following only the histologic grading criteria, it would have been anaplastic astrocytoma WHO grade 3. Under the new classification system, the diagnosis of this tumor is glioblastoma, IDH wild type, WHO grade 4. This, if you remember from the imaging, this was a non-enhancing tumor. If you remember from the histology, there was no vascular proliferation, no necrosis. However, this tumor is diagnosed as glioblastoma, WHO grade 4, because of the molecular alterations. And that's all described in these articles if you want to read more about it in additional detail or in the chapter. So suggesting grading criteria for glioblastomas IDH wild type from these update 6 of the C Impact Now working group. A glioblastoma IDH wild type is an IDH wild type diffuse astrocytic glioma with vascular proliferation or necrosis or one or more of these molecular features that are associated with glioblastoma. Third promoter mutation, which was present in this example, EGFR gene amplification, which was also present in this example. So you don't need to have both. Either one would be sufficient. And the other alteration that is associated with glioblastoma is gains of chromosome 7 and loss of chromosome 10. So combined gain of 7, loss of chromosome 10. It's also a molecular feature of glioblastoma. So any of these alterations is sufficient for a diagnosis of glioblastoma IDH wild type. And here we can see the two alterations present in this 49-year-old patient with the non-enhancing lesion were third and mutation and EGFR gene amplification. So non-enhancing grade 3 IDH wild type astrocytoma in 2016 would have been anaplastic astrocytoma IDH wild type WHO grade 3. Under the new WHO classification system, the diagnosis would be glioblastoma IDH wild type WHO grade 4 because of the molecular signature based grading system. So let's summarize the adult diffuse astrocytic disease criteria under the new WHO. On the left, we have the IDH wild type glioblastoma, which is a diffuse astrocytic glioma with either vascular proliferation, necrosis, or one of these molecular alterations, third promoter mutation, EGFR gene amplification, or combined gain of chromosome 7, loss of chromosome 10. And on the right, we have the IDH mutant diffuse astrocytomas, which are now called astrocytoma IDH mutant, WHO grade 2, 3, or 4. Difference between grade 2 and 3 is increased mitotic activity, and the astrocytomas IDH mutant WHO grade 4 will show either vascular proliferation or necrosis or CDKN2AB homozygous deletion. This is a very exciting time to be working in the field of neuro-oncologic diagnostic medicine with all these new advances in our understanding of the molecular alterations that drive brain tumors and the new advances on imaging. So over the next years, we should expect further changes in these two spheres, the molecular signature and imaging characteristics, which are rapidly evolving and facilitating a more precise diagnosis for brain tumors. Thank you very much. If you have any questions, you could email Dr. Fuller directly at gfuller@mdanderson.org.